Okay, we'll get started. We are very fortunate to have Dr. Gillian Kolla join us this afternoon. Gillian is a public health researcher who holds a Banting postdoctoral fellowship at the Canadian Institute for Substance Use Research at the University of Victoria. She uses community-based qualitative and ethnographic research to explore how to make health and social services more accessible to people who use drugs. Gillian has also been on the scientific planning committee for this year's conference and has made very important contributions to our organization of the conference. And Gillian will be talking about key findings from the preliminary evaluation of safer supply programs in Ontario. Welcome, Gillian.
So thank you very much for joining me today. So as Abby mentioned, I'm here to present some of the preliminary findings from a program evaluation that we conducted with the London Intercommunity Health Centre with their Safer Opioid Supply Program. In terms of disclosures, it's important to mention that London Intercommunity Health Centre has received financial support for their Safer Supply program from Health Canada through the Substance Use and Addictions program. I also received funding for this evaluation from London Intercommunity Health through their SUAP fund to conduct the evaluation that I'm going to speak to you about today. And in terms of my financial disclosures, I have received grants from the Canadian Institutes of Health Research and the Canadian Network on Hepatitis C, as well as receiving consulting fees primarily for the development of evaluations, as well as the conduct of evaluations at several community health centers, as well as across Ontario, as well as some community organizations. I'm also an employee at the University of Victoria at the Canadian Institute of Substance Use Research. It's also important to note that I will be using the generic names of medications as much as possible in this presentation today. The one exception is when I'm using participants' quotes. If they use a brand name medication, then I will say that brand. This is primarily going to come up when speaking about hydromorphone, which is used off-label in safe supply programs. A lot of participants you will see in the quotes will refer to this as Dilaudid. So just to note that that is where I'll be talking about a branded medication rather than using the generic name for the medication. So just a bit of background context before we get started. It's very important to note that when we're talking about safer supply programs, they're being scaled up as an intervention to address the overdose crisis, which has continued to worsen in Ontario at a particularly alarming rate. I use this graph, this is available on Public Health Ontario's website, to illustrate this trend, but also to illustrate the fact that when we're speaking about interventions to address the overdose crisis, we have to make sure that we're targeting the right problem. That very dark blue line that you see shooting up there starting in about 2016 is the presence of fentanyl in postmortem toxicology after somebody has died from an opioid-related toxicity death. And as you can see, this has gone up remarkably quickly, including an immense jump from 2019 to 2020. In fact, across Canada from January 2016 till September 2021, we've lost over 27,000 people. This includes over 6,000 people in 2020 alone. We don't have full statistics yet for 2021. However, it's very clear that this has continued to increase slightly from 2020 to 2021. The COVID crisis has been awful. There was a 60% increase in Ontario in overdose-related mortality from 2019 to 2020. And when we're talking about the overdose crisis and this awful toll that overdose-related deaths are taking in our communities, it's important to note that this is unregulated fentanyl that has taken over the street supply that is primarily responsible for overdose-related deaths. And when we look at the contribution of different opioids to opioid-related deaths in Ontario, you can see this very, very clearly in that in 2020, and this is information from the Ontario Drug Policy Research Network from a report that was published earlier this year, 87% of all overdose-related deaths in Ontario had fentanyl directly contributing to opioid-related death. This chart is interesting because it also provides the contribution of different pharmaceutical opioids to opioid opioid-related deaths in Ontario as well, and you can see that they are very substantially lower than from fentanyl. In the box there, you'll also see the contribution of unregulated benzodiazepines, which are increasingly being added as adulterants in the fentanyl supply. And as of 2020, 46% of all opioid-related deaths in Ontario had an unregulated benzodiazepine contributing to death. And so I think that it's very important to recognize that when we're talking about the environment in which safer supply programs are beginning to operate, this is the unregulated drug supply that we're dealing with. It's an incredibly volatile unregulated drug supply, and it's getting worse. In fact, just this past week, I helped facilitate drug testing for a supply from a Southern Ontario city that was causing multiple overdoses. And we actually tested a sample of fentanyl that was 77% fentanyl. And just for context, regularly in the drug checking program here in Ontario, in Toronto, the fentanyl they check is approximately 4% concentration. And so we see this very, very wild and unwieldy unregulated drug supply currently at the moment that is responsible for the overdose mortality we're seeing. So just to give you a little bit of background now, to shift gears and talk more specifically about the Safer Opioid Supply Program at London Intercommunity Health Centre. This program was started in 2006, very small, very slowly, and it was funded by Health Canada's SUAP program in March of 2020. So it's about 2 years now that they've been receiving funding. The program takes a harm reduction approach to addressing substance use. And I think that it's very, very important to note here that the model for the Safer Supply program is a primary care model, where every patient of the Safer Supply program becomes a registered primary care patient of the community health center. This means that they have access to a very large social care team, as well as access to comprehensive medical care, as well as a targeted and tailored prescription of Safer Supply opioids that's tailored to their individual needs. The evaluation that I conducted, I partnered with London Intercommunity Health Centre about 2 years ago now, and we developed some long-term evaluation plans. The first step in the evaluation was actually to conduct this internal program evaluation that I'm going to speak to you about today. This is part of a much larger program evaluation, as well as a larger program of external research that's happening in various safer supply programs across Ontario. But for this particular program evaluation, the real goal was to get at the impacts of the Safer Supply program on clients themselves. We really wanted to get the perspectives from both clients and staff on what was working well and what could be improved within the program, so that they could take those recommendations and roll them into program improvement and quality development within the health center. So at the very end, we'll talk about some of the recommendations that the evaluation makes for both the program as well as for the larger health system. This evaluation, we conducted surveys of both clients starting Safer Supply and asking them about the 6 months prior to beginning the Safer Supply program. We also did a survey with current Safer Supply clients, asking them about their previous 6 months on the Safer Supply program. And we complemented these survey results with focus groups with clients and staff. I also did a focus group with people on the wait list for the Safer Supply program, so people who were not currently clients of the Safer Supply program. And the reason was we wanted to talk a little bit about what that experience was like and what some of the capacity issues were that were facing the program. So just to give you a little bit of an idea of the numbers that the Safer Supply program is dealing with, when the SUAP funding started on April 1st, 2020, they had 112 clients, 67 women, as well as 45 men. It's important to note that that gender breakdown is a little bit strange, overwhelmingly women. That's likely because the physician who is running the Safer Supply program had been and is still conducting a outreach program for women who are street involved in street level sex work in London. And so that is one of her practice areas. And so there are a lot of women who have been enrolled in this program due to that focus of hers. During the time of the evaluation, a year and a half, there was 152 new clients enrolled and 16 clients who are no longer being followed by the program for an overall retention of 94%. And then you can see down below the number of encounters in that time period that SOS clients had with both the healthcare team as well as with the social care team. And all in all, there was just under 250 clients in the program at the end of September 2021. Now, to talk a little bit about the program impacts, in the next section, I'm going to go between some of the qualitative results, some of what people told us about their experiences with the program, as well as some of the survey results that we had from people. And so when we talked to clients about the impact that the Safer Supply program was having on their lives, overwhelmingly, we find people telling us that this program has been extraordinarily good for them. In the first quote here, you can see that the person is talking about how they've got their family, they've got housing for the first time in a long time, and that this is a major change for them. The second person here is talking about how they have interests now, that they're starting to do a lot more in their lives, instead of being this guy who hustled and robbed everyone. And overwhelmingly, when we talk to people on the Safer Supply program, they talk about how it has also saved their lives. They really feel that this program has been crucial for them in helping them not only to maintain but improve their health since beginning it. When we asked people about their use of unregulated opioids, so use of opioids from street supplies, you can see that for people starting the Safer Supply program, we have about 91% of people reporting injecting unregulated opioids, as well as 91% reported smoking or snorting fentanyl in the 6 months prior to starting the program. For current Safer Supply clients, the percentage of people who are currently injecting unregulated opioids drops dramatically to 46%. You still see about 85% of people who are reporting smoking or snorting fentanyl. And again, I think this is important, and we'll get to this in the recommendations. There is currently no smokable form of Safer Supply that's available in Ontario, and it's not available. There's no form available for the London clients as well, which means that if people prefer to smoke their opioids, which we've seen a very large shift across Canada actually over the last few years towards more and more people reporting smoking fentanyl, then we don't have any options available for them under the current medications available. When we look at daily injecting and daily smoking, we also see a fairly dramatic drop among the Safer Opioid Supply clients, particularly when focused on the injecting, with 60% of people saying that they were injecting fentanyl daily prior to beginning the program, dropping to 32% among people who are on the program. And again, the number of people reporting smoking fentanyl daily drops from 75% to 57%. So again, less of a drop for the people who are reporting smoking fentanyl. In terms of the qualitative quotes around fentanyl use, people speak about fentanyl as essentially playing Russian roulette, that you don't know when your time's up, when your ticket's there, your ticket's there. Speaking about the enormous overdose risk involved with using fentanyl from the unregulated street supply. People know that it is a major risk that they're taking. However, they often don't feel like they have any other options when they only have that available to them. Another major finding was when we asked people about their fentanyl use, one of the major things that they would talk about is how much being on the Safer Supply program, or here this person calls it the D program or the dilaudid program, is that it's the amount of money that they're spending on fentanyl every day that drops dramatically. With this person talking about his fentanyl consumption dropping from $500 to about $40 a day. And so I think it's important to recognize the ways in which that has such an impact on the daily lives of people. We'll hear this over and over again from people within the Safer Supply program, that it just frees up so much of their time and their lives that they don't have to spend trying to make enough money to support their fentanyl habit when they're using fentanyl from the street supply. Interestingly, we found that 35% of the current Safer Supply clients reported that they were no longer injecting drugs at all. Now, this is interesting because as a harm reduction focused program, there is not an overall goal of getting people to stop using drugs by injection within London's Safer Supply program. The program very much follows clients' individual goals. And so if a person has their own goal of wanting to change their mode of administration or the types of drugs that they're using, using, then they'll support them for that. But this was an interesting finding, again, because it is not the main goal of the program, yet you're nonetheless seeing a very dramatic drop in injection drug use among clients who have been on the program for at least 6 months. In terms of overdose is clearly one of our major endpoints that we're looking at. When we asked people who were coming into the program, 59% of people starting Safer Supply said that they had experienced at least one overdose in the past 6 months. When we talked to current Safer Supply clients, this dropped to 23%. Among people in the last month, 33% of people starting Safer Supply had said that they had suffered an overdose in the last month, with only 11% of current clients saying that they had suffered an overdose. And so once again, we're seeing a pretty dramatic reduction in not just the overdose risk, but the actual experience of overdose that clients are reporting to us after they have been in the program. And when speaking to clients qualitatively, one of the things that people said is you're keeping it monitored. Whereas me, I'm going to go out and I'm going to buy fentanyl, and then I'm going to buy way too much, or I'm going to buy whatever. This is you putting me at a safe dose so that I'm not going to go and overdose on whatever. And if we just step back from this quote for a second, I think what's really, really interesting here is that people really do recognize that the unregulated drug supply is so incredibly toxic and volatile. And they really do appreciate and consider the doses that they're getting and the pharmaceutical opioids they're getting from the Safer Supply program to be a much more safe option, with this participant calling it a safe dose for themselves. In terms of homelessness and food insecurity, we asked people about their experience of homelessness in the past 6 months, as well as about difficulties in finding enough food to eat in the past 6 months. And I should note here that the London Intercommunity Health Centre, the program, the health outreach program of which the Safer Supply program is part of, its primary goal is to provide healthcare services for people who are very street involved, people who are experiencing homelessness, and that is their primary client base. And so we asked about experience of homelessness and food insecurity, and we unfortunately found very, very high levels of both. And also, unfortunately, we found that there wasn't a large difference in the experience of homelessness between clients who were starting Safer Supply and clients who were on the program. And I think that unfortunately this speaks to the larger environment that we're currently in Ontario, as well as across the country, where we are in a very, very dire affordable housing crisis, where there has been a lot of difficulty in meeting the housing needs of people in our communities who are on low incomes. And unfortunately, this very much seems to be the case in London, as well as in other areas. In terms of food insecurity, people did report slightly less food insecurity. But again, I think that when we think about the structural factors, the structural vulnerability that people are facing, we see that there is just such a large experience of homelessness and food insecurity among the people who are accessing this particular Safer Supply program. One of the findings when we asked people about their ability to look after themselves, people really reported that being on the Safer Supply program allowed themselves the time and the space to take more care of themselves. The first person here says that explicitly. In the second quote, this participant talked about how they've gained weight. They've gained about 50 pounds. Interestingly, this actually set off a whole conversation in the focus group where people were talking about how they used to, when they were street involved and using fentanyl from the unregulated drug supply, that they couldn't keep weight on. And now they were actually talking about different weight loss strategies that they felt like they might have to start employing because their health had increased so much and they had gained weight when they were on the program. People also spoke quite touchingly about improved relationships with family members since starting the Safer Supply program. Several people talked about how the stability from being on Safer Supply meant that they had more time to connect with their children and their grandchildren, to really develop a relationship with them. And it was very, very touching to hear these stories. This was an unexpected benefit of the programs from the client's point of view. Most of them didn't set out to start safer supply in order to improve their family relationships. But it was very much one of the unexpected benefits that they spoke of, and they spoke of quite touchingly during the focus groups. In terms of involvement with criminal activities, we spoke to people about their involvement in criminal activities to either pay for or get drugs in the previous 6 months. Among clients starting safer supply, about 86% reported involvement in criminal activities in the previous 6 months. This dropped very dramatically to 38% among current safer supply program participants. And with about 47% of people reporting that their involvement in criminal activities had decreased since starting safer supply, about 9% reporting their involvement in criminal activities stayed the same, and 44% reporting no involvement in criminal activities at all since starting safer supply. And I was a bit hesitant to present this particular data point in some of the evaluation findings that I was given, because there's such a stigma around people who use drugs and involvement in criminal activities. But I think that it's very, very important to actually look very openly at these type of data points, because if we're actually really looking at what we can do to improve people's lives and to improve our communities as well, I think that it's very, very important to recognize the ways in which the switch in the drug market from heroin to fentanyl, being such a short-acting opioid that people have to consume so many more times in a day than when they were using heroin before, that this has really made a huge impact in people's lives. I think it's one of the more nefarious consequences of this switch in the drug market to fentanyl that we don't talk very much about. In terms of decreased involvement in criminal activities, people spoke about how for them, this was a very, very striking improvement, with one person saying, I haven't broken the law since I've been on it, and I haven't robbed anyone, and people aren't afraid of me right now. And that kind of feels good. There's a lot of people look at me and be afraid because they knew they're going to get robbed. Yeah, this program's really helped that way. I haven't been to jail and my record's looking better. So you really see here in the statements from people on the program, the ways in which this has directly impacted their lives and their self-esteem as well. In terms of involvement in sex work, as I mentioned before, one of the physicians involved in the Safer Supply program at London Intercommunity Health has a practice working with primarily women who were involved in street-level sex work in London. Among people starting Safer Supply, about 50% of people said that they had been involved in sex work to pay for or get drugs in the previous 6 months, with this dropping to 20% among current Safer Supply clients. So about 18% reported their involvement in sex work had decreased since starting Safer Supply. 61% reported their involvement in sex work had stayed the same since starting Safer Supply. So this is probably people who either were not involved in sex work before or who've maintained the same level of involvement. And 21% reporting no involvement whatsoever in sex work since beginning the Safer Supply program. And here, one of the participants talks about how they don't have to go to the streets anymore to make money for their habit, to make money to pay for their pills, since they've been on the Safer Supply program. I haven't gone to jail in 3.5 years, so that's a good thing. I'm pretty much not working in sex work at all anymore, so it saved my life. And this was a theme very, very common in the focus groups with clients, where people would talk about how they weren't having to do sex work in order to pay for their fentanyl anymore, that it was very much on their own terms now, that they were able to they were able to work when they wanted to work and when they needed to work, and that this was a very net improvement for them. In terms of health services use, I think this is one of the very, very interesting data points. And we also have some research that's going to be coming out around this shortly, where we were looking at health services use among people who were on Safer Supply. When we asked people who were starting Safer Supply about their emergency department visits in the previous 6 months, 77% said that people starting Safer Supply had been in the emergency department at least once in the previous 6 months. This dropped to 45% among current Safer Supply clients. clients. I think here really you see the advantages of involvement in primary care and having a place where they could go for primary care and to have their primary care needs met. We see a similar drop when we talk to people and ask them about their hospitalization and whether they've been hospitalized for at least one night in the last 6 months. And here this dropped from 36% to 11%. When we ask people about this in the focus groups, people would frequently talk about how prior to being part of the Safer Supply program, they had so many hospital visits. This first person talks about the amount of hospital visits I've had, 1 billion. I was in the hospital all the time, like blood infections and abscesses. The second person said, because of my spinal injury, I just want to get my pain managed. I don't care if it's through physio, through anything like marijuana, I'll do whatever it takes. It's not necessarily about the dilaudid program, having opioids or whatever. It's just I'm sick of being in pain and I can't even get a flipping doctor. That last quote is from somebody who was on the Safer Supply program waitlist. And I included it because I think that one of the important findings and one of the very striking findings for me, as somebody who's evaluating these programs, as well as doing research with multiple Safer Supply programs, both in Ontario and in BC, is that these programs are drawing a clientele that is very, very high acuity. These are people who have literally fallen through every single one of the cracks in our healthcare system. They're people who are dealing with multiple concurrent and often very, very major health issues, oftentimes have significant histories of traumatic injuries as well as pain conditions, and they are not having their care managed efficiently within the current system. I think it speaks to a larger issue with access to primary care for a population experiencing different forms of vulnerability and marginalization, but particularly for the group of folks who were on the Safer Supply program, they really saw a huge increase in their health by having a primary care physician who they were able to access on a regular basis due to their involvement in the Safer Supply program. And in fact, when we asked people overall about their physical health, on the left, you can see what people starting the Safer Supply program told us. When we asked how they would rate their level of physical health, 55% of people starting the program said that it was poor or very poor, 27% said that it was okay, and 18% said it was good or excellent. Among people who've been on the program for at least 6 months on the right, you can see that this trend is beginning to reverse and go in the opposite direction. So 27% of people still rate their health as very poor or poor, but 35% say that it was okay, and 38% would rate it as good or excellent. So there's still a lot of work to be done there, but you can very much see a strong trend there towards people rating their physical health as much better after they've been on the Safer Supply program. We hear this in the qualitative interviews with people saying that if it wasn't for this program, I don't think I'd be here right now feeling as healthy as I do. Somebody else said, well, I've got my hepatitis C taken care of. Now I can walk with my head held high. And so really not only are people who are accessing this program getting access to the healthcare services around their substance use, but they're also getting access to a broader range of service, including treatment for infectious complications such as hepatitis C, as well as we heard very strongly from people living with HIV as well, that they were able to stabilize on antiretroviral medications while they were on the Safer Supply program as well. In terms of mental health, when we asked, these findings are even worse than for the physical health. When we asked people starting Safer Supply about how they would rate their mental health, almost 60% said they'd rate it as very poor or poor, 32% rating it as okay, and 9% rating it as good or excellent. And again, we start to see some movement in the right direction here, but much, much slower, with 43% saying they would, people on Safer Supply saying they'd rate their mental health as very poor or poor, 32% saying it was okay, and 25% saying it was excellent. I think that one of the important impacts of Safer Supply program that we're probably not talking enough about and focusing enough on is this impact of being within a community health center where they can receive primary care as well as the wraparound social care options for people. So here this participant is talking about how before they really felt like they were getting very bumped together care, where they had one person watching their homelessness, one place, one person who's going in and out of prisons, but there wasn't one person who was looking into their whole lifestyle. It's all little blocks and everybody's taking a little piece of you, but nobody's putting you all together into one until you get into this program. And I think that this really speaks to having a kind of one-stop shop model where people can get access to a variety of different primary care, health care, and social care services in one place. And so I think that it's important to think about how it's clear for people that having access to the pharmaceutical medications from the Safer Supply program is a crucial part of what they're describing as a form of stability and the improved health that they're experiencing. But having access to the wraparound forms of health and social care is also a huge, huge part of this as well. In the next section, I'm going to speak a little bit about some of the major challenges that we identified in the evaluation. These are a little bit of the pain points, the issues with the program, and the places where improvement can happen going forward. The major challenge that came through in all of the group with clients, the group with staff, as well as the group with people who were on the wait list, was the high level of demand for the program. As one client said, I think the problem is that there's not enough doctors doing it. That's the problem. Another person talks about how it took them 2 years to get on the program, and that was them coming at least once a week, begging to get on the program. I think I would change that, make it a little easier to get on the program for people who need it. In the context of London, there is only currently one clinic that's offering Safer Supply, and so there is still a very, very high level of demand, despite the fact, and they're currently closed as well for new clients because they have reached capacity currently. And this is a problem that we've seen in other places as well. We currently only have a handful of Safer Supply programs funded across the country, and they have very, very real capacity challenges. The other issue, and I raised this a little bit before when I was talking about the need for smokable medication options as people have switched to smoking fentanyl because it's so much more potent. But we heard a lot from clients that they would very much appreciate different medications and new medication options. Here, people talked about in the first quote, if we had heroin, people would give up the Dilaudids for the heroin. I heard this quite frequently within the focus group. That people really missed heroin, in particular because it has legs, in particular because it has a long-acting component to it, and that they would switch back to heroin if it was made available. The other thing, though, that's important to note is that a lot of people really like fentanyl. People like the potency of the fentanyl. They like the high from fentanyl. This quote, the last quote on the slide is, "I like it better. I get a better buzz from it." And you heard this quite a bit from clients who were on Safer Supply, who were liking Safer Supply, who had dramatically decreased the amount of drugs from the street market that they were consuming, but they still liked to inject a point of fentanyl every once in a while, every day, every week. It depended on the person, because they got this very potent high and they very much liked the buzz from it. And I think that we have to talk a little bit about, in just a larger sense, about how we can meet the needs of people who, now that we have had a drug market that is overwhelmingly fentanyl for over 5 years now, how can we meet the needs of a group of people who really have developed a preference for this very, very potent medication? Actually, there was a Globe and Mail article just this morning talking about a program in Vancouver where there's a physician who is now selling heroin or selling fentanyl to clients of her current program. And so I think that we need to start thinking about really, with an unregulated drug market as potent and as volatile as it is currently, how can we meet the needs of people for the medications that are necessary for them, especially given the way in which fentanyl has just driven up tolerance remarkably in the last 5 years. One of the major findings of the evaluation also was that while people felt that they were getting a very high level of health care and very compassionate care within the Safer Supply program, they were having very negative experiences with other aspects of the healthcare system. And so when I asked people about negative impacts from being on the program they didn't anticipate, people would frequently talk about getting judged within other healthcare settings. They talked in particular, interestingly, not necessarily that other healthcare providers were stigmatizing or discriminatory towards them, but that other healthcare providers were stigmatizing towards the doctor who had started the Safer Supply program, in this case, calling her a pill pusher. And then the second quote on this slide, where somebody said, I've had doctors say, I don't agree with what she's doing. And it's like, you guys don't understand what we go through on the streets. You know what I mean? If she wasn't helping me, I'd be in jail right now. You know what I mean? And I think that this is an important quote because one of the things that really came through very clearly in the focus groups was that people felt that they had been neglected and abandoned by the healthcare system generally before they started in the Safer Supply program. And then after they started in the program, this program, they felt it was really helping them. It was helping them to stabilize themselves. This person says it was helping me to not be in jail or on the streets. And then they would go into other healthcare settings, and other healthcare practitioners were unable to see the benefits that it had for them. And it really did create this feeling that people weren't seeing the impacts that it was having, which was interesting to me because I think that we talk a lot about stigma and discrimination within the healthcare system, but it was an interesting manifestation of it that we found within this evaluation. Another issue, and this is very, very linked to the stigma and discrimination towards people who use drugs, as well as towards people who are on safer supply programs, was in terms of continuity of care during hospital admissions. Here, when participants would talk about having to go into the hospital, even for planned admissions, the first person, I had major surgery and they didn't agree with the program, so I went through withdrawals right after major surgery. The second person saying, well, they classify us as junkies once we go into the hospital. And then from the focus group with staff members, when people would speak about it, they would talk very much about how even when they were attempting to increase and to have continuity of care, when they were attempting to work with hospitals and healthcare providers within hospitals to smooth the experience of people who had to experience admissions, they said that they were having fairly consistent wretched interactions with the hospital and with getting people into the hospital. This is not, I don't think, shocking because we hear this very frequently from people who use drugs when talking about their experiences with the healthcare system. What I do find interesting is that even when you have an attempt by other healthcare and social care workers to work with hospitals, they were still hitting many, many walls. And people still very much felt, clients of the program still very much felt that they were getting punished by getting put into withdrawal after they would have a surgery or during a hospital admission. In terms of sharing and selling of medications, we asked people questions about what they were seeing in terms of the sharing and selling of medications. This is a major concern that you often hear voiced around safer supply programs. And so we asked quite a few questions for people about it. Several people told us about how they would never share, or they only very rarely shared, because as this person says, I'm greedy with my stuff. It's very rare that I'll share my meds with anybody. And I'm like, you know what? I'm sorry. I need this. The other thing that we heard from people is that selling and sharing of medication was often very much to do with what their level of fentanyl intake was. So as this person says, depending on the person, depending on how bad their fentanyl intake is in a day. If they need, say, 0.5 gram of Fetty, they'll get rid of their script to get as much Fetty as they can. You know what I mean? And so again, I think if we take a step back, this really, really speaks to how it's quite difficult with some of the medication options available within safer supply programs right now to meet the needs of all of the people who have developed very high tolerances to fentanyl due to years of exposure to fentanyl in the street supply. We're now hearing quite regularly people report intakes of over 1 gram a day of fentanyl. And when you do the conversions, that actually translates into quite an astronomical MME in terms of the equivalence, the morphine equivalence. Most of the programs right now are having a very, very hard time catching people at the current high levels of tolerance with the medications that are available. And so I think that there was this feeling among participants that some people were in fact selling or sharing part of their script so that they could buy the fentanyl that they needed in order to meet their tolerance needs. But that it was difficult from the data that we had available to determine how frequently this was happening. What was very, very clear was that it was difficult for people when they were faced with a situation where friends or family members of theirs were not on the safer supply program, and they were, particularly if they had been watching their friends or family members experience repeated overdoses from using the street supply. And this person talks about how I think family members first, your spouse, like you can't be on it and not expect to be splitting with your spouse. That's just common sense. You're not going to be sitting there doing your dope and watching your spouse get sick. That's not happening. And so I think that here this speaks to the difficulty in terms of the dynamics of if you are one person in a partnership with your spouse, if you have friends who you're watching have overdoses repeatedly, and you have a safe and regulated supply of a medication while they are using an unregulated supply that's exposing them to the street supply, that it can be very, very difficult not to share with them in order to reduce their risk and their exposure to the street supply. One of the findings as well was that at London Intercommunity Health Centre, they don't have an on-site supervised consumption site. And people there, although there is another supervised consumption site in London. Several people told us that they would very much like a supervised consumption site on site at the London Intercommunity Health Centre. When they spoke about the current supervised consumption site, they said that they feel comfortable there, nothing's going to happen. I can do my hit and relax for a bit. The second quote here about having a place where people could watch out for each other. The outdoor place where they gather to use is actually across the street and behind a set of buildings very close to the London Community Health Centre. So there's already a community response to the overdose crisis where people are watching out for each other in this outdoor location where people are gathering to use, but that people would very much prefer to have an indoor monitored place where they could go. In terms of, again, this is just focusing on how this is an internal program evaluation. There was several staffing considerations that were raised as issues. People very much spoke about how they need more staff and right now, and they need more prescribers in particular, more space, about how particularly the confluence of the COVID pandemic with the overdose crisis had created a situation where people were extremely burnt out and being run off their feet. People really, really emphasized the need to have peer workers and how important having peer workers and peer support within the program was for people. So just to end off, I'm going to speak really quickly about some of the recommendations that we found, both the program level recommendations as well as the system level recommendations. These very much follow from the findings that I've been going through here today. Unanimously, the major recommendation was a need to increase capacity through increasing the number of prescribers. This came through very clearly from both people in the program as well as from staff, that it was impossible for them to meet the current level of community demand with the capacity and the prescribers that they had available right now. People who were not part of the Safer Supply program expressed incredible levels of frustration about not being able to get on the program and not knowing about what the process was to join the wait list or the triage criteria. And so one of the recommendations was also for a clearer communication around program details such as this to people who were on the wait list. A continued expansion of wraparound services, particularly around the need for affordable housing and helping people and supporting people towards affordable housing was necessary. However, it's very important to note that here, when I would ask staff about this, people were saying, well, yes, I can't refer people to housing that does not exist. So I think that right now we really have to come to terms with the fact that we're having a structural level issue with a lack of affordable housing throughout our communities. And this is going to continue to impact our ability to provide health and social services. You can provide as much health and social services you want to somebody who's using or who's living in a tent in a park in Southern Ontario when it's -40 in the middle of winter, and nothing is actually going to improve their health as much as just getting them into an apartment that they can afford. In terms of emphasizing harm reduction strategies through education campaigns, there's a recommendation for that, as well as to offer supervised consumption services on site at London Intercommunity Health Centre. Some clients also stated they would appreciate accompaniment and pharmacy pickups, as well as multiple different ways to have their medications, including having pharmacy deliveries for them. Especially this was an issue for people who had much lower mobility, and expressed that it was quite difficult sometimes for them to get to the a pharmacy on a regular basis, and then advocating for program expansion and increased pharmaceutical options. I think that most of the evaluations that I'm seeing coming out of safer supply programs right now across the country is speaking about the need for an increased access to different medication options, including injectable medications, including heroin. People really highlighted how heroin would be useful because, and adding heroin to the formulary and having it available. It's one of the health systems recommendations here because heroin is actually a smokable opioid. And so for people who have transitioned or who have only started fentanyl and are using it through smoking, having heroin available on the formulary or as an option within safer supply programs would allow for an option, a prescribed option for people who are smoking their drugs. Again, in terms of health systems recommendation, and this came up, it was one of the questions I think to Jason in the previous and absolutely spectacular keynote address, was in terms of expanding coverage for high dose injectable formulations. This has very much limited the ability in Ontario in particular to expand injectable opioid programs, and is very necessary. And a major system level recommendation is around addressing stigma and discrimination within the healthcare system. This is such a huge need, and it was so marked in the ways in which people spoke about their experiences in the healthcare system. Even they would go in to the healthcare, they would need to have an emergency room visit, and they were expecting, I remember one person was telling me about how they expected that it was going to be a better experience for them because they had stabilized on safer supply, they weren't using any street opioids, they'd gained weight. I think that their words were, "I don't look like a street junkie anymore." And then they went into the emergency room, and they still received absolutely discriminatory care because they were on the safer supply program. And they spoke about how much that made it so difficult for them to think about accessing healthcare services in the future. And this includes, again, the continuity of care that's necessary when people need to access healthcare services or have hospitalizations. So just to step back really quickly at the end of this presentation, I just wanted to speak for a moment about the current landscape in Ontario. So this is an evaluation that's very specific to the program in London. I just wanted to highlight there's currently SUAP funded programs, safer supply programs in several cities in Ontario, mostly in community health centers within harm reduction programs and working again with the street involved population. And because of the major capacity issues, most of the programs are very much limiting themselves to a high acuity population who are experiencing very significant health harms from their use of fentanyl from the street supply. There's also an increasing number of individual physicians working outside of larger programs who are themselves prescribing safer supply. And I think that there's several remaining research and evaluation questions that are going to be very interesting to answer over the next few years in terms of the impacts of availability and access, the benefits for clients of participating in safer supply programs, as well as some of the safety concerns and the risks around scaling up these programs. And I think it's very promising. There's several different research teams, as well as a national safer supply research project that's ongoing right now. And so I think we're going to have a lot of very high quality research coming in the next few years. Just to highlight some of the research that's already been done in the Ontario context, one of the major questions early on around safer supply programs, one of the major concerns that was raised was whether or not safer supply or hydromorphone, injection of short-acting hydromorphone was leading to increases in infectious complications. I was part of a team that actually used health administrative data from ICES to look at trends in hospitalizations for serious infections among people with opioid use disorder. And here we looked at a fairly long time frame of several years, and we did in fact find that there was increasing infectious complications across the province of Ontario, which mirrors a trend that has been found across North America. We failed to find an association between having been prescribed short-acting hydromorphone and infectious complications. I think that this is an important thing to watch going forward. My own personal hypothesis is that the ways in which fentanyl has permeated the market in North America, and especially because fentanyl is so short-acting, so people are having to inject several times a day and much more than in times when the street drug supply was heroin, I think is one of the factors that we should be looking at in terms of a reason behind the very, very fast rise in infectious complications among people who inject drugs. If you're looking for some information around safer opioid supply prescribing in Ontario, I was also part of a team that looked to characterize, again, using health admin data, some of the prescribing that's already happening, as well as the prescriber characteristics and the characteristics of other opioids that were being prescribed as backbones at the same time. And so you can find some more information there. I'm a bit stretched for time, so I'm not going to go into it here. And as well, we're starting to see some information. This is a very new paper, I think just from last week, that's coming out of BC. It's a qualitative paper looking at the impacts of the risk mitigation prescribing, or the scale up of safer supply, that happened in British Columbia starting due to the COVID pandemic in 2020. So we're starting to really see some research coming out on the safer supply programs. And I think that this is going to be a very fruitful area over the next little while. And there's going to be an increasing amount of evidence about the different impacts of these programs that will really increase the evidence base in this area. So I'm just going to end there. I have put my email address up, particularly because, oh, it went away really fast there, but I put my email address up because some of the papers that I referenced, especially at the end there, are behind a paywall. So please, if you are interested in getting those papers and you don't have access, please don't hesitate to send me an email, and I'm very, very happy to share the PDFs because the academic paywall system is awful, actually, in terms of making sure that knowledge is spread around. Oh, thank you, Abby. I appreciate that.
Thank you so much, Gillian. That was a fantastic talk. Particularly appreciated the depth and breadth of the evaluation approach that you're taking. I have a bunch of questions for you, but I'm going to turn it over to the participants first. So the first question that we have is from Rob Boyd. And he says, relying on individual prescribers to scale safer supply has proved challenging. What do you see as the benefits and challenges of moving to a public health model for safer supply? If you need clarification about what Rob means by a public health model, he's given some additional details.
Yeah, I think that that's an excellent detail. That's an excellent question. And I really appreciated Jason's thoughts in the keynote just now, because I think here I'll be very, very clear that I'm providing my own opinion on this, because there's a wide variety of different opinions about this within particularly the community of people who use drugs in terms of how safer supply should be scaled up. I do think there is a place for medicalized safer supply. So medicalized safer supply where individual prescribers are prescribing as part of a comprehensive package of care. I think that the model of providing it within primary care, where people have access to a wide range of medical and social services, I think is a very, very strong model, particularly for catching a lot of the folks who, because of different forms of systematic marginalization, have fallen through the cracks in our system. I do think that individual prescribers and medicalized models are not going to address the overdose crisis in any large scale. We found in the paper that I had noted there about safer supply prescribing in Ontario that about 500 people were currently being prescribed safer supply in Ontario. Just compare that to the 2,500 people who died of opioid overdose in 2020 alone. It's a drop in the bucket right now. And so I think we do need public health models of regulated drugs for people who don't feel like they need medical care alongside access to regulated supply of drugs. I think that we are so far behind. We needed decriminalization a long time ago. And I think that there's several models of regulated supply that we could be looking at using and scaling up very, very rapidly to try to provide alternatives to the unregulated supply, which is right now the dominant market supply. And the difficulty with maintaining this as an unregulated market is we don't have market levers or regulatory tools we can use to intervene in an unregulated market in the same way that we can intervene in a regulated market. And so I think that we need to do both. I think we need medicalized safer supply, and I think it's useful for some people, but we definitely need rapid scale up of public health approaches as well. Oh, Leah's question about stimulant use. That's a fascinating question as well. The impact of crystal meth use on reported outcomes. Thank you, Leah, for asking that. We actually do have some data on stimulant use, and particularly crystal meth use among people who are receiving safer supply. Interestingly, crystal meth injection did drop among people who were receiving safer supply. And we don't have a lot of data on that. And we're actually adding a bunch of questions around that for future evaluation cycles. I think that we've seen a really, really big shift in the way that people are using stimulants within the current unregulated market due to the presence of the unregulated benzodiazepines that have been present in the market. I think that this has really changed things. There's always been people who liked the speedball effect. So they always liked the high that came from mixing an opioid with a stimulant. I think that there's been a very strong increase in crystal meth injection, primarily not because people are looking for a speedball effect, but because people are looking to try to counter the extreme sedation that comes from the benzodiazepines in the unregulated drug supply. I've noticed this in some of my ethnographic work, that we have a lot of people who are doing a shot of crystal meth before doing a shot of fentanyl, just in case they get the benzo dope. And so I think we have to pay attention to the ways in which this is shifted and people's usage patterns are shifting, as well as the ways in which people are using the medications available to them from different pharmaceutical programs, including OAT programs and safer supply programs alongside drugs that they're getting from the unregulated market. We've tended to look at these things in isolation. So we're either looking at kind of like pharmaceutical prescription opioids that people are being prescribed, or we're looking at unregulated drug supply. The fact of the matter is a lot of people are moving between those, and with quite a bit of frequency. And I don't think we have a lot of research right now that's looking at that. And so I think that this is really an interesting area going forward. We haven't been paying enough attention to stimulant use. And I think also we're seeing a strong increase in overdose mortality from stimulants alone. And we're not paying any attention to that. Where we have drug toxicity deaths, where the only drugs being found are either cocaine or crystal methamphetamine. It's still a small proportion of the overdose drug-related mortality, but that proportion is increasing. And so I think we're ignoring stimulants at our peril at this point.
Thanks, Jill. We've got another question from Jennifer. Was there any association in infectious complications with people using short-acting hydromorphone not prescribed for them, or are you unable to tell?
So yes, so we couldn't find an association between it. And so I think that it's really the issue always when we're using health administrative data to look at something like infectious complications is that we can see prescribed medications, but we can't see Medicaid or drugs that people are taking from the unregulated market. So unfortunately, drug dealers are not giving us the information, uploading the information on the amount of crystal meth and fentanyl that they are selling and that people are using. And so that's always going to be a major, major confounder when we're looking at any of the health admin data. And so I think that in general, there is a very strong increasing trend in infectious complications. It's just that we didn't see that association with the either the short acting, and I believe there was a slightly stronger association with the long acting, but it wasn't, it didn't approach significance, although don't quote me on that. I'd have to go back and look more in detail. But again, I think that we, because we can't see, the other thing that's happening with crystal meth is that people are injecting it much more frequently. I've noticed that in the last 5 years in my work, is this very, very strong move towards the injection of crystal methamphetamine. And when you're injecting crystal meth, you often inject it multiple times. You're not just doing one injection and then you're done. You're usually doing several of them. And so I think that we really have to pay attention. We know that the amount of bacteria that's introduced into the bloodstream through every injection is fairly significant. And so when we're seeing this increase in the number of injections that people are doing on an everyday basis, and, you know, I mean, we have fentanyl of all different colors of the rainbow. It's being manufactured in unknown circumstances, the same with the crystal meth. And so I very much worry about that as what's driving the infectious complications.
Thank you so much, Gillian. I think we're going to have to leave it at there. We're at 3:20. Fantastic. And we really look forward to more work and more evaluation and more research that's going to be coming out of these programs. It's so important. And we have put your email address in there, so you may get some contacts from people for more information and for some of those articles. Thank you so much.
Yes, please don't hesitate to reach out, everybody. And thank you for coming today.